Hey, I am delighted to introduce our speakers for our first topic on bowels. So we have Terry Tenove. Terry's a spinal cord injury peer coordinator for the Southern Alberta area, and he is a person with lived experience with spinal cord injury. We also have Parmar, who is a physiatry nurse practitioner in the tertiary neural rehab program at Foothills. And lastly, Dr. Rebecca Charbonneau is a physiatrist at Foothills Medical Center. Take it away, you guys.
All right, thank you, ladies. Can you guys see the slides okay? Yeah, thumbs up. All right, so we will launch into our talk about bowel management after spinal cord injury.
So we're going to just start with the definition. What is neurogenic bowel? After the spinal cord injury, the bowels are called neurogenic bowels. So it's the impairment of the gastrointestinal and anorectal function from a lesion in the nervous system, resulting in failure to evacuate the bowels or failure to contain stool. If the lesion is above the conus medullaris, this will result in upper motor neuron bowel injury, and that will have more issues with the fecal constipation and fecal impaction. And if the injury is below the conus medullaris, that will result in lower motor neuron bowel, mostly the issues with the sphincter, weak sphincter. So that will lead to more fecal incontinence. We will go more in detail in these two types of bowels. Next slide.
So I'm going to go over a little bit of high-level neuroanatomy. The bowel has three separate nervous systems innervating it. So you have the autonomic or automatic system, which includes both parasympathetic and sympathetic. There's the intrinsic or enteric nervous system, which is nerves that are within the walls of the GI tube. And then there's the somatic nervous system. So this is the part which allows for volitional control over when to have a bowel movement. This diagram is the enteric nervous system. So you have the myenteric and the submucosal plexus within the walls. And this is where medications like Senokot will work. This nervous system can function independently and thus is even active after a spinal cord injury. With this alone, though, the gut motility is quite slow, and it's normally influenced at least partially by that autonomic nervous system. And then here's a diagram showing both the autonomic nervous system and somatic nervous system together in the large bowel. The thing I want you to note here are the areas on the spinal cord where the nerves to the gut originate. So at the top is the brainstem, and that's the vagus nerve. And then T10 to L2 is the sympathetic section. S2 to S4 at the bottom is both parasympathetic and somatic. So those are sort of the important areas. The GI tract is going to function differently depending on where the spinal cord injury occurs, so which level is affected. The major cutoff that's used in most references is somewhere around that T10 level to differentiate between the upper and lower motor neuron bowel. If the injury is above T10, it's often upper motor neuron versus below is the lower motor neuron. And so today what we're going to do is discuss these two different bowel routines that are recommended after the spinal cord injury. There's some reflexes to be aware of. So many reflexes can remain after a spinal cord injury. More reflexes tend to be intact after upper motor neuron injury compared to lower motor neuron injury, though. So two of the important reflexes to know about include the gastrocolic reflex. So this reflex causes increased bowel activity after a meal. And this is the basis for performing a bowel routine after a meal in all bowel routines. So whether it's upper or lower, you'd still want to try to time it after a small meal or coffee, that sort of thing. And then there's the rectocolic reflex. And this reflex causes peristalsis or gut motility in response to mechanical or chemical stimulation in the rectum or anus. And this is the basis for using a suppository and digital stimulation after an upper motor neuron injury. Bowel transit time is greatly increased after spinal cord injury. So when you look at the studies, 31 hours has been quoted as the average time from mouth to anus without a spinal cord injury. This extends to 86 hours after a spine injury. And in some studies, the reports are actually even over 100 hours after a motor complete cervical injury without the use of any stimulants or medications. Our goal of this talk is to have you come away with knowing what a bowel routine is and how to choose between the upper motor neuron and lower motor neuron routines. So the bowel routines need to be individualized to the person with spinal cord injury, and they need to be taught to the patients and or their caregivers. These can and likely will evolve over time as the injury progresses, or sorry, not progresses, but as time goes since injury. And the aim of the bowel routine after spinal cord injury is social continence. Now that bowel function has changed, we want a reliable routine that's predictable, scheduled, and one that prevents incontinence, and a routine that leads to regular bowel movements without bloating or constipation.
So going further into upper motor neuron bowels, as mentioned earlier, this is a lesion above the conus leading to descending inhibitory signals from the brain that normally control our gut. This results in overactive segmental peristalsis and underactive propulsive peristalsis, making the colon more prone to localized contraction and less efficient at propelling stool. In a nutshell, what Dr. Charbonneau just mentioned, it increased the colonic or transit time from mouth to the anus. And another added issue is spastic external anal sphincter, and it will not be under volitional control after the spinal cord injury. So these two things added, it leads to constipation and stool retention in upper motor neuron injury. Next slide. So when you're seeing these patients with upper motor neuron bowels, if they don't have a proper bowel routine or a bowel routine is ineffective, what you are going to find? You are going to have these patients who are more FOS, full of stool. So the symptoms that you will see are going to be delayed evacuation with overflow incontinence, loss of appetite, nausea. This all constipation is going to lead to abdominal distension. With their spinal cord injury, their respiratory muscles are already compromised. This abdominal distension will lead to more compromise in their respiratory system as well. If you examine these patients, their reflex arc is present. So you will see their anocutaneous reflex and bulbocavernous reflex are present. And the other thing you will find is, like I mentioned earlier, the sphincter is more spastic. You'll have more tone in the sphincter, so more fecal retention. So what are the treatment goals? So like Dr. Charbonneau mentioned, our goal is to have a predictable formed bowel movement every day or every second day without any incontinence. So that is our goal in this bowel, in these kind of bowels. So I'm going to, so when we manage these patients with a proper bowel routine, we can reduce the incontinence from 64% down to 4% if we can manage them. That's what the studies have shown. So now I'm going to ask Terry. Terry, can you just tell us can you just tell us what your level of injury is and how you manage your bowels?
Yeah, so my level of injury is a C5-6 AGB quadriplegic. So when I first left the hospital, I was doing a daily bowel routine. I would take Senecot the night before I do mine in the morning. So I take my Senecot or medications the night before, and then I would wake up in the morning. I would have breakfast or a coffee, and then put in a suppository. And then when things get going, I'll put myself on the commode chair, and I will perform digital stimulation. So I'd use a caregiver or a tool, and do a digital stimulation to help with evacuation. And then I do that every 5 to 10 minutes until nothing comes out. If nothing comes out after 1 or 2 digital stimulations, then I would end my routine and get on with my day. Since then, I've now gone to every other day. I wasn't having great routines every day. I would have one day a good one, sometimes not. And it was a little all over the place. Since I've moved to every other day, I've had more predictable and better routines, which has helped to actually decrease the time.
Okay, thank you. Just a comment on the constipation. Just keep in mind that the constipation is a known factor for increased neuropathic pain, spasticity, frequent bladder infections, and will trigger autonomic dysreflexia as well. So that's why it's really, really important to make sure our patients are on a good bowel routine that they can manage in their lifestyle. And like we mentioned about the stool consistency, in this upper motor neuron, we want to keep the stool consistency, soft to firm, type 4. Our nurses are fairly familiar with the Bristol stool chart. For my allied health colleagues, this is just for you when you guys tell us in team conferences, patient having some bowel accidents, you can just tell us with the types of bowel accidents they're having. Just kidding. I won't put you guys on spot for that one. But moving along, just pay attention to type 3, which is going to be in our lower motor neuron, and type 4, that is more for upper motor neuron bowel routines. So we'll go into how we manage these bowel routine. Next slide. So upper motor neuron bowel, by now you understand that the transit time is increased and the sphincter is really tight. Those are the 2 things we need to work on with these bowel management. So to decrease the transit time, we use a stimulant to help the bring stool down. So most of the times we will use is Senna or bisacodyl or a little bit of a PEG as well. And then the stool is down now in the rectal area. Now we need to evacuate that stool. Our body does not have the function to push that stool out. So we will take advantage of the reflex arc that is present by using the digital stimulation to relax the internal and external sphincter and plus suppository to cause some irritation and peristalsis in the lower rectal area to empty the bowels. That's our basic bowel routine. We will start on most of our patients with the goal to have daily to every second day bowel routine with no bowel accidents. And with the goal always is going to be to keeping the bowel routines under 45 minutes or so. And to achieve that goal, sometimes the type of suppositories we use plays a huge role. So in on our unit, we use a suppository called Magic Bullet, which is a bisacodyl suppository with the water base instead of being the regular suppository that has an oil base. So what's the difference? The water base will dissolve faster in the mucous membrane compared to the regular suppository. So this will cut down the time, evacuation time in half. So that's why we use Magic Bullet suppository in all our spinal cord injury patients. Terry, what kind of suppositories do you use or have you tried in the past?
Yeah, so when I was in the hospital 14 years ago, magic bullets weren't as prevalent or known. So I was just on a regular suppository. And it made for a lot more difficulties with planning my routine. The big issues is, like you said, it takes a little while to melt and start the process. And so with the goal of not being on my commode for as long as possible, and you have to kind of time it and play around with it. But sometimes you're now worried, if you're going to start evacuating before you get on the commode chair. So obviously you get on early, you'll be sitting there for a longer period of time before things start getting going. So switching to the magic bullets, it's a pretty quick transition. Once I get it in, by the time I'm over the toilets, usually things get going really, really quickly for me. The other noted difference also was I usually get a slimy discharge later in the day a lot of the time, wet parts, for example. And so the nice thing is I've noticed that switching to the Magic Bullets is decreasing that greatly. If I don't think I've had one in years, so I think it was a big part of that.
That's a really good point, Terry, about the mucus discharge. I think a lot of our patients do complain about that, and I'll keep that in mind as well to suggest them to switch over the suppositories. And another one is out there is mini enemas, or called enemies. So those sometimes are available in Canada, sometimes they're not. But at the same time, my review from our patient population, they do work fairly good if you can get your hands on those ones. So if this is the basic bowel routine, we call it, doesn't work, then we look into other options. What are the other options? So there's a next step would be transanal irrigation, which is literally a water enema, fancy name for water enema, but it does have a rectal catheter that can reach up to the sigmoid colon or higher up in the rectal area, and the water could reach higher up in the descending colon to empty the bowels a little bit better. And sometimes the advantage of transanal irrigation, the other name is Peristeen, made by Coloplast. So the advantage is that people with a good hand function should be able to use the Peristeen on their own. As compared to water enema that most of the time nurses are doing in hospital. So transanal irrigation does have a really good evidence showing that it could reduce the constipation and will reduce the bowel accidents as well. And the time we switch patients to this is one, they're having accidents, bowel accidents, or their routine is taking really long. That's the time we will bring transanal irrigation. Keeping in mind, it is expensive. Some insurances will cover Peristeen, others will not. So that would be another deciding factor when we decide if we need to choose this one or not. Terry, have you had any experience with this?
Yeah, so I was having a routine that was a little bit longer. It was starting to get around an hour or more on a consistent basis. So I had heard about this and then decided to give it a shot. I've also heard, it can be very effective at cleaning and you're out. So wanted to try it out. The problem is with my level of injury, I don't have very good hand dexterity, if any at all. And it's kind of a complicated, it's not overly complicated, but it's, you got to know what you're doing and be able to use your hands. So I would have to get caregiver support. And just with it's a lot more involved and unfortunately not something that's easy for caregivers to do as well, if they're not experienced and background in it. And I didn't have very good routines or experience with it at all. It was just not a fun situation. So I decided to try some different things. But I went and so I focused a little more on my diet, but also on more activity, getting in the standing frame more often, electrical stim, biking, with some pads on my abdominals and just more activity. And actually found that got me right back under 45 minutes and much better routines that way. So kind of opened my eyes that there is alternatives and other things that I could look into.
Yes, no, thank you. That's a really good point that, diet plays a huge role. Activity is going to play another big role as well. So those are always recommended that people look into their diet and the activity as well. So if the transanal irrigation doesn't work, patients still having some incontinence, then we look into the surgical options. There's a MACE available, the surgery, which is I haven't seen one done in my career in here over 20 years, but it's more favorable, I think, in a pediatric population where they use the appendix to create a stoma at the abdominal wall. And because the appendix is right at the start of where the stools start getting a little bit harder. So once the stoma is created, the person could flush the stool with a catheter, with a 30 to 60 minutes, they sit on the toilet and able to flush the gut out. So sounds really good, but I haven't seen one done. So the other option that we do see in our practice a lot is if people still continue to have issues, we will look into colostomy or ileostomy to manage their bowels at that time. Next slide. So then we kind of look at overall the bowel essentials, like we mentioned about importance of inserting the suppository and the digital stimulation, making sure our goal always is to make sure our patient are independent with their care, they're independently able to do their bowel routine or able to direct their caregivers how to manage their bowels. So those two things become really important when you're teaching a caregiver. What is digital stimulation? It's going to relax the sphincter and help them evacuate. And how do you insert the suppository? Those kind of things are, really essential for the caregiver to know. But at the same time, sometimes it's really hard and tricky to teach those things. So that's why we like our patients to know it so they can teach their caregiver as well. As you guys can imagine, it's a really hard task to teach the caregivers. I'm going to put Terry on again and ask Terry if you have had issues with caregivers or what's your experience has been with caregivers.
Yeah, so I've had many caregivers over the years, and it's different in Edmonton and Calgary, and so usually when I had a new caregiver come on, and they would send out a RN or somebody to help with the training, and they would always observe first, the suppository insertion and the digital stimulation and teach them how to do it. The problem being that they usually showed up, never had done it before, and so their first time is being taught how to do it on me. I'm being a guinea pig, and they can talk them through it all they want, but like the how far to push the suppository in and how aggressive people do digital stimulation. Every caregiver is a little bit different, and luckily for me, I have a little bit of sensation down there, so I can tell the caregiver, hey, you're going too hard, or they're not doing enough, and it's basically gonna not do anything, or you've gone in too far. But if I wasn't in that situation, if I had zero feeling down there, I definitely had some caregivers where it could have been a really bad situation. So it was a little frustrating that unfortunately a lot of them would show up with zero experience or zero background in doing digital stimulation and suppository insertion.
Yeah. So it's a good thing that you know it, so you can teach your caregivers, right? So that's always the goal for us.
Mm-hmm.
And so then our allied health team will play a huge role in the equipment procurement as well. So we all know the commode chair needs to be padded to prevent any skin injuries. And for a side cut, if the patient is able to do it themselves to do, insert the suppository and able to do their bowel routine to allow the independence. And then the other piece we do look into is sometimes, digital stimulator and the sup inserter, other equipment just to increase more independence if they are able to use those devices, given if they have a hand dexterity. So Terry, what's your experience with the equipment? What do you use at home?
Yeah, so I have a commode chair, much like the one you actually see there, but mine's front end opened. I've actually found recently that I had it on the side, but had a lot of difficulty using my digital stimulator. And as soon as I changed it to the front and reached in from there, I had much better access. So a lesson learned that way for my ability. And then, yeah, I use a digital stimulator. For years, I didn't. It scared me, for one. It's hard with your hand dexterity and different things like that to do it very well. But my wife and I were going on a honeymoon, and I had to learn how to do it or bring a caregiver with me. So I had learned how to use it. And, I found one that does a right angle. There's different kinds and different shapes. So it's nice to have the options. The suppository inserter I've tried. The hard part is it's tricky to line things up and do it properly. And I also found when I did do it once, the suppository wasn't inserted very well. So yeah, yes, you can get a suppository in, but it's not as easy or fluid as when somebody does it themselves.
Yeah, no, thank you. Those are good points. Next slide, please. So now we're just going to cover the medications we use on our unit, I'm just going to comment on when and how we decide to choose different medications. So bulk forming agent, most of you guys know the Metamucil. If most of the times I would use this one when patient is lower motor neuron injury to bulk up the stool, because you do, and if you remember the Bristol stool chart, I said you want it a little bit on the firm side. So if their stool is too loose, I will use the Metamucil. Always remember it's a fiber. If you're increasing a fiber intake, you need to work with the water intake as well, and otherwise it will really constipate you. The other prokinetic agents that we use, upper motor neuron. If you could remember, the stool transit time is increased. We need to bring the stool down, so we will use the stimulant Senokot to start with. But if they're still having difficulty with their bowels, we will add bisacodyl. And if patient has gastroparesis, like if diabetes history, so we will add another prochlorperamide as well to bring the stool down. Moving along, the other ones that we will use osmotic, which PEG, everyone knows PEG. So I have love-hate relationship with PEG. So PEG, what it does is it's osmotic, so it's going to soften the stool. So if the stool is really hard, we will use PEG. And as soon as you start seeing patients having more accident, or if their stool is really soft, I will back off PEG. And magnesium citrate, love the drug. I will use it for bowel cleanouts. So 300 mils, that's just for bowel cleanout. I will not recommend this for daily use. Keep in mind, when you're cleaning using magnesium citrate, keep in mind an electrolyte imbalance as well. So then we have stimulant and osmotic, both kind of combined. Bisacodyl will do that. So it's a we use it more as a stimulant, but it does cause a lot of cramping. Keep that in mind if you're using that one. Mini enemas, like I mentioned earlier, sometimes available, sometimes not, but they work beautifully. So I'm going to pass it along to Dr. Charbonneau.
Switching gears now. So we'll talk about lower motor neuron for about a minute or two, since we're running low on time. The key thing to know about this is that those reflexes are not going to be there. So generally the external anal sphincter is denervated, and this leads to incontinence, especially with things like Valsalva maneuver. So think about any transfers, coughing, sneezing, that sort of thing. Patients not only describe incontinence, but on exam, you're also going to notice that the tone is decreased and that anal wink reflex is also gone. On inspection, you'll notice a difference. So the images A and B show a normal rectal verge. And this would also be seen in a patient who has an upper motor neuron lesion. The images C and D, this shows the expected appearance after that lower motor neuron injury. So if someone has cauda equina syndrome, for instance, there's going to be an atrophic external sphincter and a flattened or scalloped appearing anal area. In this type of bowel routine, the stool needs to be firm and formed. So this helps prevent incontinence. And the routine can be done daily or up to 4 times a day. Some patients will do a bowel check after every meal, for instance. Typically, patients are taking Metamucil. Often patients will try a suppository, but if there's no nerves to that area, the suppository will not work. And then you just switch to manual disimpaction. Positioning with feet up on a stool can be quite helpful. And then as far as complications, these can actually happen in any bowel routine. Things like hemorrhoids, abscesses, ulcers, fissures, and prolapse are all things that we see. This is a summary slide that kind of compares the 2 different routines. So again, that main difference is the lack of tone and lack of reflexes with the lower motor neuron bowel. And so in this case, suppositories usually won't work. And digital stimulation is often not effective. So patients need to use manual evacuation. This is a slide to screenshot, just kind of summarizing our talk. So upper motor neuron generally starts with Senokot 8 hours before a suppository and digital stimulation. And then in lower motor neuron, we're just bulking up the stool with Metamucil and using disimpaction daily to multiple times a day to help prevent bowel accidents. And here's some of the resources that we use to put together this presentation. So if you look up Care for Persons with SCI on the AHS website, there's lots of resources. So about bowel, but also autonomic dysreflexia, bladder. The Spinal Cord Essentials website from Toronto is excellent. The PVA guidelines are very good as well, and these are all free. And then any of the fact sheets from Queensland are also quite helpful. So thank you very much, and we're happy to take any questions in the chat.
Great. Huge thank you to all of you guys. Thanks, Terry, Raj, and Dr. Rebecca Charbonneau. I learned a few things in there too, even though I help out with education. So thanks so much for sharing. Do we have any questions in the Q&A? I would encourage, if you do have questions, we're not able to unmute you, so please feel free to type those into the Q&A, and we've got one. Okay, so we have a few popping up here. Are you better off to overtreat than undertreat is our first question, and that's from Sarah.
Oh, that's a good question. I don't know if one's better than the other. Like, I feel like, we're really trying to make an individualized bowel program, and it takes time. I guess we didn't say that enough over this talk, but
Right.
yeah, generally the bowel is really slow to respond to things. And so if we make a change, we try to make just one change and then wait at least 3 or 4 bowel routines. So if it's every day, so 3 or 4 days, or if it's every second day, 8 days to see the effect. Gosh, like overtreating is going to lead to incontinence. So I don't really want to do that, but undertreating is going to be constipation and nausea. So yeah, I think like maybe not overtreat, but maybe like if you're really having a hard time, do a bowel clean out. So do the MEG citrate, do tap water enema, start with a clean slate and go from there.
Okay, thank you. We have another question here regarding, they didn't see anything about the use of lactulose in there. Do you guys have anything to say about that?
Yeah,
Do
we
you want me
don't
to? Oh,
use a lot of it, mainly because we find that it causes a lot of gas and bloating. However, it can be used for sure. It's similar to Restorelax or PEG 3350. So we'd use it more to like titrate the stool consistency, but often it's not our first choice.
and the results could be very unpredictable from lactulose. So the ones we choose, like Senna, is very predictable. So it works in 8 hours in most patients, and we can figure it out and titrate it accordingly. So the ones we listed, that's the ones we use in bowel routines. But we will reach into other things as well, but not as a first line.
Okay, thank you. We have a couple other questions. It looks like Hardeep is typing in an answer for one about colon irrigation in there, so I'll go on to the next one. From an anonymous, it says sometimes patient has mixed lower motor neuron and upper motor neuron. In this case, do you do twice bowel routine?
Yeah, honestly, in this one, I would just stick with the upper motor neuron routine. As if there is a mixed picture, which we can see with a conus injury, then those patients often respond nicely to suppository, but perhaps keep the stool a bit more firm if the tone is slightly reduced.
Okay. Oh, we've got lots of questions popping in now here. Is there, we have one from Samir, is there any evidence in using FES in prescription of lower motor neuron bladder? Maybe they meant to take bowel.
Typically, FES is not going to work great if it's completely denervated bowel. So if it's a complete cauda equina injury, FES is not going to work. However, we always recommend patients like try it, especially like things like FES cycling that can have positive effects on bowel. And if they respond, then yeah, for sure use it. And then same thing with abdominal FES. We don't use that very much in Calgary, but there is some evidence showing it works, but you need to have the nerves there in order for that to work.
Somebody else is curious. They did work in Ontario with spinal cord injuries, and they're curious about your thoughts on the use of milk of magnesia for bowel routines rather than senna.
Yeah, Raj, do you want to take this one?
Yeah, sure. So I think the reason we use Senna is just because it's a stimulant and it works way better for this population for us and make it a little bit more predictable. Could someone use milk of magnesia? Yeah, but it just the predictability is the piece. That's why we stick to the ones we do use.
Couple more here. They would like to know, oh geez, question just moved there. Therapists would like to know what should be the target amount of time for a bowel movement using any of the options discussed. So the bowel routine length, like that time.
Yeah, good. Yeah, 45 minutes, I think, is our frequent cutoff. Once routine starts getting longer than that, patients get other complications. So pressure injuries would be sort of the number one we're trying to avoid. So we try to keep those routines less than 45 minutes if possible.
Okay. We did have another one about milk and magnesia, so thanks for answering that. Looks like we have a question from Max. Hello, I found a small anal douche helps with both stimulation and irrigation. Any input? Question mark.
Yeah, I like the product that Raj was talking about, the enemies, I think is similar to what you're describing there. So yeah, that's gonna be both sort of chemical and physical irritation causing that reflex bowel movement. So yeah, I think that's very reasonable.
Thank you. Here's an interesting one. What is the best way to ensure the proper insertion of suppositories in case the patient doesn't have any sensation, just to prevent any harm to the patient?
Raj, do you want this one?
Yeah. So what is the question is like how to insert the suppository?
If a patient doesn't have a ton of sensation,
I
how do you
think
do it safely to not
making
harm?
sure that you have lubricant, proper lubricant, and make sure that you're gently just using a gentle approach, and just it needs to be against the mucus wall. Make sure it's not going straight up into the stool, but make sure you gently place it against the mucus wall. Just lubricant is going to be your friend.
Thank you very much. Round in here from Ross, can immediate fasting be helpful or detrimental to successful results?
I think we've seen both, and I think this just comes down to how individualized each patient is. So yeah, intermittent fasting, I think some patients have found it really helpful in reducing the bowel accident frequency that they're having. And often they're doing it for secondary reasons too, right? So whether it's managing their blood glucose or if they have a goal for, body habitus, that sort of thing. But then we've seen some patients who it just doesn't work for them. So I think it's one of those things that, give it a try if you're interested, but it's hard to say if it's going to be helpful or detrimental to the individual person.
Great. And last question here, how often should one clean out with magnesium citrate be done?
I would say like if they're home, like we will do it because the hospital is more controlled environment. We're watching a lot of things, so we will do it as needed. At home, sometimes if they're not having a good bowel routine, sometimes I say, I don't know, 3 to 4 weeks. I don't think there is a hard and fast rules, Dr. Charbonneau, is there? But I always go with it, just making sure they are, appropriately hydrated because they will lose a lot of electrolytes when they're doing the clean outs. So 4 weeks would be ideal if they're at home.
Yeah, I would agree. And if you're needing like more often that for some reason, then yeah, definitely reach
Yeah.
out to your physiatrist and see if you can help change some other factors that might be causing the bowel routine to be not working as well as you want.
All right. Well, thank you to everyone who typed in their questions, and thank you again to our presenters and Terry for joining to share that very valuable perspective